President, Dr. Ravi Sachana, Treasurer, we all welcome the stalwarts in the panel discussion today. We are very proud to have wonderful um, speakers and panelists. As we would see, we have Dr. Ramesh Chaudhary, sir, from Rajasthan. We have Dr. Subhash Chandra Shaw from the Armed Forces. We have one and only Professor Shashi Vani, madam, as a chairperson on her preferred topic of skin to skin contact and KMC. We have Dr. Ravi Sachan. So we have a wide variety of faculty who are from different walks of life, from different walks of neonatal care. And we are here, the World Breastfeeding Week. The theme this year is prioritizing breastfeeding and create sustainable support system. So this World Breastfeeding Week is an opportunity to raise awareness about importance of breastfeeding and supporting parents. It's not a problem of parents or the mothers themselves to figure out what they have to do to initiate breastfeeding within the time frame which is optimal, like within half an hour of birth. Mother is under considerable stress. So the world understands that it is not the mother's job, but it's everybody's job to provide an ideal environment for the mother so that she can do what is optimally most natural way of feeding this newborn, that is breastfeeding within half an hour of normal birth and as soon as possible after cesarean birth. So this year's theme, prioritizing breastfeeding and create sustainable support system, highlights the importance and long-term benefits of hospital and community structured collaborations in supporting breastfeeding mothers. Breastfeeding isn't something mothers should figure out alone. What really matters is having skilled, consistent support system in place, especially in the hospital, now that most of the births are happening as institutional deliveries. But as we had discussed earlier, with our specialized breastfeeding consultants like Professor JP Dadit sir, Dr. Sushma ma'am, who are into Dr. Kumoda madam, who are into creating lactation support systems all over the country. But we still lag in having lactation counselors, so that once a mother needs somebody, where do we go to? First optimal choice seems to be doctors. We are a doctor-based community, but doctors hardly have any time for this job of lactation counseling, which requires a lot of patience, listening. We are good at talking, but we are not that good at listening and providing individualized lactation counseling, which such mothers require. So breastfeeding is natural, but for many new mothers, it doesn't always come that easily. The right support can make all the difference. So, Dr. Dadit sir, here comes your role as an NNF consultant and advisor on breastfeeding. You have to create a force of lactation consultants, lactation counselors in the country who help not only healthy term babies, but babies who are in NICU, so that their mothers can start expressing. There are counselors who initiate expression of milk from this mother in first 1, 2, and 3 days of life, so that very preterm babies also can be provided mother's milk. It's not about telling them what to do. It's about giving them the tools, information, and support they need to decide what's right for them and their babies. So with this background, let's have our expert faculty over here. For this, I would like to invite our president first, Dr. Manoj VC, sir. Please tell us about this excellent seminar which we are about to have on this very relevant topic of breast.
Thank you, Amit. Respected seniors and my dear friends, it gives me immense joy to be here with all of you, the stalwarts in this field, as we celebrate the transformative power of breastfeeding during this week, breastfeeding week. We all reaffirm our commitment this week to the most foundational act of nurturing, the mother's embrace and her milk. So today, let us take a moment to reflect on the incredible evolution of neonatology through the decades. In the last century, our collective focus was on survival, a race against time and fragility. Small babies, how to get them survive and all that. As we stepped into this century, 21st century, our lens sharpened towards intact survival. And in this second decade, we focus on nurturing care, placing the baby's emotional and developmental needs at the heart of neonatal medicine. And now, in this decade, our mission has matured further to precision neonatology, helping the vulnerable newborns reach their full potential physically, emotionally, cognitively, and socially. This arc of progress reminds us that neonatology is no longer about merely saving lives, it's about shaping futures. And what better way is there than prevention? Primary and secondary prevention have become our leading principles this very moment. Friends, at the very core of these efforts, we all know like two powerful evidence-based strong pillars of intervention, which even though they look so simple, are being backed up by more and more science as more and more evidence pour in. Zero separation of mother at birth and mother and baby at birth, and IKMC, and that is immediate Kangaroo Mother Care and Kangaroo Mother Care thereafter as the first pillar. And of course, exclusive breastfeeding, the second pillar, which remains the single most impactful intervention in early life. So let us again forcefully reiterate that when we promote this, the skin-to-skin contact and uninterrupted breastfeeding, we are in fact activating nature's most sophisticated healing system. The original principles of lifestyle medicine. We are in fact balancing immunity and growth, neurodevelopment and astonishing precision. And as I said, as we focus more and more on precision medicine, let us not forget the new insights also that we had gained from the Human Microbiome Project 2014, which opened actually the doors to understanding how a newborn's microbial environment shaped by birth, feeding, and contact affects long-term health. If you want these babies to develop as adults free from all lifestyle diseases, we need to start from the very beginning. So breast milk is not just nutrition, it's bioactive communication for us, a living symphony of microbiota, immune agents and growth factors designed uniquely for each infant. That is the precision neonatology that we apply here. So once again, friends, let us celebrate breastfeeding not as a tradition, but as a powerful science-backed tool for human potential. And we also need to discuss the challenges that we face in providing this highly evidence-based smart intervention, I would call it, to our tiny ones. Not only to the well babies, that of course we are always reiterate, but also the smaller and high-risk ones in NICU who are denied this basic intervention for to satisfy our act of playing God sometimes, not leaving things to nature. So we need to now understand things and let us try to bridge this gap between actually what is the science and what is the practice that we do, and try to strengthen our voice as a neonatal professional to champion these interventions. Let us ensure that no baby is left behind. No baby, however sick the baby is, should not be denied. At least our sincere effort should be there for both these pillars. The zero separation, moving on to KMC and exclusive breastfeeding, or at least provision of MOM, mother's own milk. we have a galaxy of faculty today for this great webinar, I would say. So I welcome all of them. Thank you so much, madams and sirs, for joining us. And we have a lot of attendees who are whom I would encourage to participate in the discussion at the end. So without wasting any more time, let us straight away delve into this webinar. Thank you. Over to you, Amit. You're muted, Amit.
I now invite our President-elect, Dr. Lalan Bharti, sir, to please come over and say a few words about this, the importance of this week, and what do we expect our governments to do to improve the breastfeeding rates, which are still um, not even 50% in first 1 hour. Are you there, Dr. Lalan? So if Dr. Lalan is not there, I would like to invite Dr. Ramesh Chaudhary, who is the chairperson for the next session. The next session is importance of breastfeeding, breast milk feeding in the newborns. Dr. Ramesh Chaudhary is a very senior pediatrician and neonatologist at SMS Jaipur. He looks after a jumbo neonatal unit, more than 50 bedded NICU it is. And Dr. Ramesh is a champion neonatologist, going from training many pediatricians and neonatologists in resuscitation and numerous other activities. He's a avid learner and teacher both. So he's currently the EB of NNF, Central NNF 2025-26. So Dr. Ramesh Chaudhary, sir, please join in. And after a few words, please welcome our speaker, Dr. Subhash Shaw, who is a neonatologist from AIMS, New Delhi, and is also one of the champions of neonatology in armed forces. Dr. Ramesh Chaudhary, are you there?
Yes, sir. Thank you, Amit, sir. Thanks, NNF and stalwarts of NNF for giving me this privilege. Today, without wasting much time, I'll just introduce our sober and really hardcore worker, Dr. Subhash Chandra Shaw. He's DM Neonatology and presently affiliated with the Army RR Hospital, New Delhi, working as professor and neonatologist. He has a good lot of works with 85 publications, 9 chapters, and 1 book. And he won many awards. And let's, without any wasting, I just hand over the mic to Dr. Subhash. Sir.
Thank you so much, sir, for your kind introduction. Good evening, everyone. The talk is on importance of breastfeeding. Actually, from time immemorial, we know about the importance of breastfeeding for the baby, for the mother, for the community, or for the nation at large. But it does need a lot of reinforcement at times because the rate of breastfeeding is still not as optimal as we would imagine. So to start with, the British obstetrician, that is Grantley Dick Red, he had this famous quotation, quote unquote, a newborn baby has only 3 demands. They are warmth in the arms of its mother, food from her breast, and security in the knowledge of her presence. Breastfeeding satisfies all 3. So before going into the effect or the importance of breast milk, let's see the picture that is there as on today. And as we see, there has been improvement in breastfeeding rates, as we see from NFHS 1 to 5. But the gap between the institutional delivery and the early breastfeeding, initiation of breastfeeding rates are not really commensurate. I mean, we can see 88.6% babies are today born in institutions, but the initiation of breastfeeding on day one and within the first hour of life actually is just 41.8%. So there's a gap, big gap. And let's see what are the other parameters as on today. Then if we see NFHS 5 again, and we find that, well, in first 2 months, the breastfeeding, exclusive breastfeeding rate is 75.7%. But in just next 2-3 months, it has come down to 48.9% again. That means that at 4 to 5 months of age, when ideally 100% of babies should have been on exclusive breastfeed, not even half of them are on exclusive breastfeeding. And by this time, other milk, plain water, all of them have actually started. So now coming back to our age-old knowledge of human milk, and as we know, there are like three patterns, and as per the days, colostrum, transitional milk, and mature milk. Very basic that colostrum is present before delivery and in first few days after delivery, but it has got very high host defense proteins and secretory immunoglobulin A, and so it is infant's first immunization. Now in IgA also, immunoglobulin A also, what is very interesting that the amount of A2, IgA2 is more in human milk and in colostrum, which actually is not denatured by the gastric acidity. So beautifully, A2 is more found in breast milk. Then we have transitional milk that occurs within, in first 2 to 5 days postpartum till about 2 weeks of life. And it is transitional in composition between colostrum and mature milk. And then the mature milk starts, which is more watery in consistency. And again, it has got two parts, foremilk and hindmilk. Foremilk is rich in water, mineral, proteins, and vitamins, and hindmilk is rich in fat. So foremilk, is more for thirst, and hindmilk is more for satiety. So in colostrum again, which actually is the best thing to give to a baby, and there we are actually lacking in that first day of feeding or in the first hour of feeding. Now there are so many advantages of colostrum, like it is very antibody rich, and so it protects against infection and allergy later on. It has got many white cells which protects from infection. It's a good purgative. So clears meconium, it helps to prevent jaundice. There are certain growth factors which help intestine to mature, and it prevents allergy and intolerance. And also it is vitamin A rich, which reduces severity of infection and thus prevents eye disease. Now, this article I got while making the slides, and I was amazed to see the amount of components that is there in human milk. But note here that many of these things are inherently deficient in a newborn and more so in preterm baby. But the human milk has got everything, like all the immunoglobulins, primarily the IgA, which is most important, and in that also IgA2, which doesn't get denatured by gastric acidity, as I said, and so it helps in preventing infection, mostly the diarrheal infection. Then there are so many other things like your lactoferrin and your growth factors, then different hormones, um, different kind of interleukins, then interferon gamma, then other anti-inflammatory factors, prebiotics like bifidus factor and oligosaccharides. All of them are so important. I'm not going into detail of them, but then like oligosaccharide that will prevent enteric infection and also will prevent atopic dermatitis later on. So similarly, they have each have got some role to play, and there are plenty of them. There are a lot of WBCs, there are a lot of macrophages, neutrophils, lymphocytes, and needless to say that the total counts are more in colostrum than the mature milk. So all in all, human milk is a complete product that kind of is required for the baby by all means, whether it is infection, whether it is inflammation, whether it is allergy later on, whether it is long-term diseases. I mean, each and every answer is there in human milk. So what does it actually do? So by and large, it will prevent all infections, but still, to be very specific, the risk of non-viral diarrhea, the infective diarrhea, will be higher in non-breastfed infants as compared to a breastfed infant, and the odds ratio will be up to 3 to 6. Then who are breastfed for first 4 months or so will have 3 times less incidence of severe respiratory infection requiring hospitalization, so less pneumonias. And then they are known to protect against otitis media and urinary tract infections. And then there are long-term protection against all kinds of allergy like atopic dermatitis, asthma, insulin-dependent diabetes, Crohn's disease, ulcerative colitis, tumors in infancy. So evidence is there for all of them. And one lesser discussed thing is better immune response to vaccines. Like let's say cell-mediated immunity or antibody response to various vaccines are also more in the babies who are breastfed. So this is a classic slide we must have seen many a time, but then, I mean, it's so fascinating that it helps by all means to everybody, the baby, the mother, the community, the nation. So babies are less likely to die. We will see some evidence also for that. There will be less diarrhea, respiratory infections. There will be better bonding, better growth, better nutrition status, lower risk of chronic diseases, even lower risk of overweight and obesity later on, and needless to say, improved cognitive and motor development. And it helps mother also so much that mother is less likely to become pregnant in first few months after birth, then lower risk of maternal cancers like ovarian and breast cancer, faster maternal recovery and weight loss, postpartum weight loss will be better, and there is less postpartum depression, which is very common, by the way. So again, often this question is asked: if mother has got fever, so should mother be feeding? Yes, mother should be feeding. In fact, it will be helping the baby. Like if mother is infected, there will be white cells in mother's body which will make antibodies to protect mother. Now, some white cells will also go to breast and will make antibodies there. And all these things, the antibodies will be passed through the breast milk to the baby, and it will actually protect the baby. So that is what the power of human milk or mother's milk. So now let's see what is the pattern of initiation of breastfeeds as per NFHS 5. Is it like the same on the day 1? No, it is not so. If within 1 hour of birth, the breastfeeding rate is 41.8%, the same figure, once it is like if we see 1 day of birth, that is first day of birth, it is 86.8%. But does this matter? Does this really matter that whether the baby was fed in first hour or first day or even later? Let's see that. So, what is the risk of neonatal mortality according to time of initiation of breastfeeding? This article is from 2006, and there is a recent article also. I'll just talk about it later. Now, breastfeeding was in this study, breastfeeding was initiated within the first day of birth in almost 3/4 of babies, and by end of day 3, almost all were breastfed. Now, the risk of neonatal death was much higher, fourfold higher in children given milk-based fluids or solids in addition to breast milk. So there was a marked dose response of increasing risk of neonatal mortality with increasing delay in initiation of breastfeeding from day 1 to day 7. And the overall late infection was associated with a 2.4-fold increase in risk. Now, this is very important because this needs to be tackled, needs to be addressed. As you see here, see within first hour of birth, the risk of mortality, if it is 0.7, the same thing has become 4.2 times if breastfeeding has been started after day 3. So very important take-home point. Now, what about in India? Is there any data about neonatal mortality as per timing of initiation of feeds? Yes. Women who did not breastfeed their newborn within the first hour after his birth, the odds of neonatal mortality had increased to almost threefold as compared to those neonates who had breastfed within first hour of birth. So the point is that the population attributable risk estimates that the risk of neonatal deaths could be reduced to almost 15% if the babies would have been exposed to early breastfeeding from the present level of breastfeeding. Again, a very important point that the mortality can actually improve neonatal mortality if we just make sure that the babies are being fed in the first hour of life. And it supports the protective effect of early breastfeeding initiation on deaths within the first 28 days, including all-cause mortality. Some more data. Now we go into retinopathy of prematurity, which is also a big problem in India because a lot of preterm babies these days, almost 13 to 15% babies are preterm today, and there is unregulated oxygen use, and there are many other things. We're not going into detail of it, but let's see how does breast milk affect retinopathy of prematurity. Well, those babies who were fed human milk were shown to have less ROP, all kinds of ROP. The relative risk was 0.76. That means almost 25% protection. And the number needed to treat to avoid one or prevent one case of ROP was just 11. That means 11 babies, if are more 11 babies are fed breast milk, the ROP rate will also decrease. That one ROP can be prevented. And what about severe ROP requiring treatment? In that case, the NNT is 33. Again, it's almost 1/4 reduction in ROP in case the babies are fed human milk. What about sepsis? Is there some data on that? Yes, one systematic review which came in 2018, it says again 30% reduction in sepsis, primarily late onset sepsis in preterm and low birth weight babies if they are fed human milk. Now, the next slide is even more interesting, that those preterm and very low birth weight babies, if they are given even 50 ml per kg of human milk, then also there is a lot of reduction in sepsis by almost 40%. So all these figures and evidence is so fascinating and so important to implement that it can change the situation in our country or in general if we insist on giving human milk. But the best evidence of human milk in preterm babies is regarding NEC. There is a definite reduction in risk of NEC by odds ratio of almost 3 in case babies are fed human milk. It came in repeated studies, and last Cochrane, so as recent as 2024, that also says that donor human milk reduces the risk of NEC by almost half. Now remember, the donor pasteurized human milk is not even as superior to a freshly given human milk. So maybe in freshly given human milk, this reduction will be even more. So there is definitely a reduction in preterm babies as far as NEC is concerned, ROP is concerned, and sepsis is concerned. And of course, mortality is less in case babies are fed human milk for many reasons. Now, if we see about the cognitive outcomes or motor scores or developmental outcomes, definitely hands down, those babies who are fed breast milk, they have got better cognitive scores or motor scores and lesser neurodevelopmental impairment. So to summarize, the take-home message of importance of breastfeeding is that it is the most natural milk for a baby with every anti-infective property and anti-inflammatory properties are there. It reduces mortality, NEC, sepsis, and ROP as there is plenty of evidence as on today. There are better vaccine uptakes, which is really a very important thing because we are giving so many vaccines, and there is so much of evidence today that those who are on breast milk, their vaccine uptakes will be better, the immunogenicity will be better. And of course, there are long-term benefits as well, like better development, better neurodevelopment, less allergy later on, less diabetes, and some more long-term diseases. So all in all, there cannot be a better substitute to human milk. And the key is early initiation of breastfeeding as early as we can. That first hour, that should be our approach, and that will really change the situation as on today. Thank you so much. I've finished.
Thank you. Thank you, Dr. Smash, for this wonderful elucidation of literature about evidence-based advantages of breastfeeding, which go beyond diarrhea, pneumonia, mortality to NEC and ROP as well. So I would like Dr. Ramesh, any comments, sir?
Sir, very nicely elaborated and clear-cut message sent. But it's really sad to know that breastfeeding rates are declining or not improving as we expect. And for that, we have to build upon the social support system. And for that, each and every person, including society members, doctors, and the parents and families, we all should take this on a mission mode to achieve the benefits of this great science. Shall we proceed for the next
Yes, sir.
session?
So we can, is Dr. Lalan here? So we can go on to the next topic. For this, I would like to invite the most coveted speaker the most coveted person in the country, um, who is best suited to chair this session, Professor Shashi Vani, madam. Um, she goes much beyond the title she has held as Emeritus Professor of Pediatrics and Neonatology at PS Medical College in Gujarat, Karamsad Medical College. And she can be said to be the mother of KMC, immediate skin to skin contact care, in our country. She has promoted Kangaroo Mother Care in India like nobody has ever done before. And she is a wonderful proponent of breastfeeding. And I would like to invite Dr. Shashivani Madam to please chair the session and introduce the session on skin to skin contact and Kangaroo Mother Care, relevance and needs. And the speaker shall be Dr. Ravi Sachan. I would also take the opportunity to welcome Dr. Sugandha Arya, who is also a wonderful proponent of Kangaroo Mother Care and IKMC or immediate KMC soon after birth, even in NICU and MNICU. Welcome, Dr. Sugandha.
Thank
Over
you,
to
Dr.
Shashivani,
Amit.
madam.
Thank you.
Thank you, Doctor.
Thank you, Dr. Amit. I'm really humbled and honored to be here with all so many experts. Now, I will just like to take up from here that our earlier speaker emphasized very well on the early initiation of breastfeeding. And for that early initiation, as our president also has mentioned, early skin to skin contact on mother's chest immediately after birth is one of the very important intervention, and also several other factors. I'm sure our speaker will bring out that. Dr. Ravi Sachan, he is a professor of neonatology and he has helped Neonatology Forum also in many ways and an ardent supporter of breastfeeding and kangaroo mother care. And here I must mention that I must congratulate NNF for bringing these two topics together. For past so many years, we have been talking about early initiation of breastfeeding, and repeatedly I have been requesting different forum people to introduce early skin to skin contact and kangaroo mother care also in their training programs, also in their advocacy programs. But somehow I fail to note anywhere it is mentioned significantly. And I am glad now NNF has taken up that topic and they have introduced this concept of early skin to skin contact, early KMC, and also the importance of zero separation, which is much more important in the care of small and sick babies, the highly vulnerable group with which we are concerned. So, with this background, I will request Dr. Ravi Sachan to start. As I already said,
Are you
he
here?
is also an
Dr. Ravi?
ardent
Yes.
trainer in breastfeeding and kangaroo mother care and so many other aspects of newborn care. I request Dr. Ravi, please.
Ravi is our treasurer for NNF for the 2025-26 year as well.
Thank you, madam, for your kind word of appreciation and introduction, and thank you, Amit sir, for encouraging. Today, I'm going to discuss about the little skin-to-skin contact in KMC and how it is relevant as of now, or how it is needed to promote the early and exclusive breastfeeding among the newborn. So our objective is for today's presentation is to recognize that evidence-based benefit of skin-to-skin contact in KMC in the newborn healthcare, and to inspire and empower the healthcare provider to promote and practice the skin-to-skin contact in KMC. As we all know that India is one of the world largest newborn is delivered in our country, and it is also the one of the largest country in the world who has got a highest neonatal mortality. With this background, if the neonatal mortality is to be continued and we could be able to lose the human capital by 2035 with estimated around 2.9 million neonatal death and approximately 15.1 million newborn would be disabled by 2035. and very ambitious plan in our India Newborn Action Plan, which envisages that our single-digit neonatal mortality rate to be achieved by 2030. And similarly, our Niti Aayog Sustainable Developmental Goal also target that neonatal mortality to be achieved 12 per thousand live birth by 2030. And we all know that national health policy is also targeting that by 2025 only it would be achieved by 16. And we know that presently we are means we are in the way to achieve these neonatal mortality, hoping to continue, and we will be able to achieve these target by 2030 or NHP in next few days. As my previous speaker also reiterated again, I'm reiterating again that our institutional delivery as per the NFHS 5, if you look at the data from previous NFHS 4 to 5, that we have increased from 79 to 89% of institutional birth. And if you look at the particular urban area, then we have almost reached to completion, that we are 94% now. So it is a very huge number as far as institutional delivery is concerned, as Dr. Amit Upadhyay also reiterated earlier. And if you look at the key performance indicator about the percentage of deliveries assisted by the healthcare worker, that means all the deliveries which are assisted by a trained healthcare worker is close to 90% or 90%. But the percentage of early initiation of breastfeeding within 1 hour is very poor. If you look at the rate of urban delivery, it is around 45%, and if you look at the rural area, it is around 40%. So this is a very very huge gap, as shown by the Dr. Subhas also. And but why it is matters in 2025 and beyond? How it is relevant now, and what is the need of skin to skin care contact and KMC henceforth? Because India still faces high neonatal mortality and low exclusive breastfeeding rate. Skin to skin contact and KMC are the low cost effective and scalable solution. We know that, and it very much align with our national health mission, national health policy, WHO and SDG to achieve the single digit neonatal mortality. And one of our studies in from our country, from the Safdarjung Hospital, what we call the IKMC project, IKMC study has already shown it has a potential of reducing neonatal mortality by around 25% as compared to the conventional KMC, and it can prevent neonatal death as tuned to as 1.5 lakh uh, newborn globally every year if this model is adopted universally. And the study also shows that the babies who nurtured in the or who cared in the MNCU had a 35% less incidence of low temperature, that is hypothermia, and 18% less infection as compared to the baby cared at the conventional neonatal intensive care unit. As we all know that skin to skin care contacts and KMC is not synonymous with each other. The skin to skin contact is to be initiated immediately after birth in the mother's abdomen, and that is to be practiced within 1 hour of that is within the golden hours. And the KMC is an extension of skin to skin contact, where the infant is held in the upright position between the mother's breast and the skin to skin contact is being prolonged and continuous for that matter. And it has got a three component, that it is a continuous KMC and exclusive breastfeeding and early discharge and follow up. So with this information, so this is how the skin to skin contact is provided immediately after birth. The baby is being delivered over the mother's abdomen, and after clamping, delayed cord clamping, baby is placed over the in between the chest over the mother's abdomen with a bare chest, and where the temperature can be maintained. Early initiation of breastfeeding within 1 hour that facilitate skin to skin contacts, and thereafter the skin KMC is to be continued in the ward or in some other area. The relevance of KMC in skin to skin context, which to the breastfeeding success is very much known. Why it is relevant? Because it has a critical window for preterm babies. It reduces in preterm mortality maximum by up to 40%, and it maximizes the chances of breastfeeding, that is early initiation and successful establishment of breastfeeding. And a significant correlation is between the skin-to-skin contact and exclusive breastfeeding. And skin-to-skin contact in KMC is one of the best facilitator for improved latchment in the milk transfer, and it promotes a better bonding, and there is hormonal benefit for the maternal and as well as for the neonatal also. So why the need of skin-to-skin care contact is because it regulates the body temperature, it maintains the heart rate and the breathing, reduces stress and promote the sense of security, and it support the brain development and immune system. It releases the oxytocin, facilitating bonding and milk production and uterine contraction for physical recovery in the mother, and reduces the maternal stress and anxiety associated during the delivery, and it promotes the early colonization of maternal flora. And what is the need of KMC thereafter? It stabilizes the body temperature, promoting thermal control, reduces the risk of infection, promote and sustain the breastfeeding, reduces mortality rate in the preterm infants, encourage growth and development, that is holistic development of the baby, and increases the breast milk supply, facilitate the mother-infant bonding and enhance maternal confidence. It reduces the stress and anxiety associated with the care for the preterm baby in the mother. Implementing the skin-to-skin contacts or KMC in our clinical practices, how we can implement better to achieve these the goals of the skin-to-skin contact in KMC. That we first committed with the protect the golden hours management, that is to start skin-to-skin contact immediately after birth. Trained and motivated staff is very much required who are taking care of the deliveries. Facilitate the process of successful establishment of the feeding. Antenatal counseling and multiple sessions may be required, very important to require achieve these goals. And the daily independent clinical round for KMC and breastfeeding is required, and regular audit to be done during the clinical round. As we all know that Amrit Kaksh is in a part of the human milk bank design where the KMC is promoted in practice while collecting the express breast milk, and the zero separation and direct skin to skin contact on the mother's chest soon after birth must be promoted in all deliveries. The labor room protocols need to be changed accordingly to facilitate, and the written protocol has to be there. Some of the success stories from the fields also suggest that if we implement the skin to skin contact in KMC, that helps in the neonatal healthcare. One of my studies published in BMG Open Quality in my facility, it uses the point of care quality improvement methodology to improve the newborn care immediately after birth. That takes care of all the essential newborn care practices. Here is a little bit busy slide, but you can see as Vani ma'am also stressed that pre-delivery counseling or the counseling before antenatal counseling is very much important to sensitize the mother for the to prepare for the mentally prepare for the delivery during the delivery room. So what we did in my facility, it was a structured pre-delivery counseling was there. Before the start of the study, it was not administered, but during the study, we oriented our staff room, and then we, delivered a pre-delivery structured counseling. Then you can see here, as the pre-delivery counseling goes up, and then the skin-to-skin contact is also very parallel increases, and the acceptance is more than 95% if we counsel the mother beforehand. And apart from the delayed cord clamping and early initiation of breastfeeding is also improved. So what was the impact of this study done it at my facility? Overall improvement in the uptake of essential newborn care, that is pre-delivery counseling, skin-to-skin contact, delayed cord clamping, and exclusive early initiation of exclusive breastfeeding in a bundled care approach. Increased exclusive breastfeeding rate at the discharge, which is around more than 95%, and the better coordination and teamwork between pediatrician, obstetrician, and nurses. An improvement in the mother's birthing experience was the most satisfying the outcome. Another study is done at my facilities also, that to estimate the optimum duration of skin-to-skin contact to achieve the normothermia. As we all know, the government facilities are very much overcrowded, and we don't have 45 minutes or 1 hour of time, to practice for the skin-to-skin contacts in a busy unit. So we with this we done the study to to look at what is the optimum time for to achieving normothermia at 20 minutes, 30 minutes, and 40 minutes. So what we concluded that total 525 babies newborn recruited, and you can see at the 30 minute of the skin to skin contacts, almost all the babies at around 95, 96% to 97% were able to achieve 30 minutes of skin to skin contacts. And these early initiation of skin to skin contacts facilitated for the early initiation of the breastfeeding. So almost all the babies who are able to practice the skin to skin contacts are able to breastfeed within 1 hour. So what we concluded that even the 30 minutes of skin to skin contact is required to achieve normothermia. It is very much feasible, doable, scalable, even the high delivery facility, public sector hospital. High rate of babies were discharged within the breastfed within first hours, and the discharge was on exclusive breastfeeding. So what is call to action for for message for all the neonatal healthcare worker? Prioritize early skin to skin contacts and promote KMC in every eligible newborn. Advocacy for promotion and policy implementation. Empower mothers through counseling and emotional supports. Proactive involvement is crucial. Key performance indicator for skin-to-skin contacts and KMCs to be included in NFHS surveys reports, and skin-to-skin contacts or KMC to be included in the lactational counselors training program. And together, let's build a safe and breastfeeding friendly ecosystem for the newborn. Thank you so much. Over to you, Amit sir.
Thank you. Ravi,
Yes, sir. Yes, ma'am.
before you conclude, I would like to say a few points.
Yes, ma'am.
You highlighted the importance of early skin to skin contact,
Yes,
but
ma'am.
at the same time, we would like to mention that due to some reason, if mother is not able to do it, we have the provision of keeping an alternate KMC provider or a birth companion, which is already there in the government system,
Yes,
but this
ma'am.
system is underutilized. So
Yes,
that is
ma'am.
one thing we should take. Second thing is early skin to skin contact soon after birth should be included in a routine care of all the newborns. And busy labor rooms are not the excuse. You can at the most transfer the baby on mother's chest to another place where the skin to skin contact can continue. So
Yes,
these,
ma'am.
once you realize the importance of it, you will always find the ways how to do it. So that importance has to be emphasized. That is more important. And again, in the antenatal period, just as we prepare the mother for early skin to skin contact, we should prepare one alternate caregiver also, or the birth companion who herself can act as an alternate care provider who can help the mother with the skin to skin contact. In case, due to some reasons, if the mother is not able to do it, this care provider should be able to do it, and this should be possible even in cesarean delivered babies also.
Yes, ma'am.
And
Yes, ma'am.
many institutions internationally, they are demonstrating the feasibility, utility, and the importance of early skin to skin contact even in the cesarean delivered babies. So skin to skin contact on mother's chest is an easily doable intervention with many benefits, and we should take it up on a big way for promotion of the same. And most of the situations, we just see it is passingly referred, but no active efforts are made to promote it. So that is why I said we should have an audit in each case, why it was not possible to do it and how we can improve, and so on. Anyway, I can go on like this, but all that I want to say is from here we carry at least one message, that immediate skin to skin contact soon after birth is an important intervention for early initiation of breast milk secretion as well as breast milk feeding. And breast milk feeding, I said, because many times the preterm and low birth weight babies, they may not be able to directly breastfeed. In that case, even express breast milk will have to be given. That is also an important thing. And that express breast milk also, the quantity increases if the baby is on skin to skin contact. So all these points we need to emphasize, and early skin to skin contact should become a highly recommended usual routine practice where the babies require immediate life-threatening situations, that is advanced resuscitation, babies in shock or any other congenital defects where urgent interventions are required, in those cases they can be exception. But in majority of the cases, it should become a routine. At least that one message, if we can transmit, and all the breastfeeding training programs must include promotion of Kangaroo Mother Care also. Kangaroo Mother Care, in the definition itself, it includes breastfeeding. That has to be realized. These are not two separate topics. Naturally, even for the term babies also, whatever early few hours of KMC, it is found to be very useful in the early initiation of breastfeeding. So all these points we should be able to bring out. And again, I thank NNF for taking up this topic right in the beginning, and I hope that emphasis will continue. Thank you very much.
Thank you very
Thank
much,
you.
ma'am, for your expert comments. I would like to invite Dr. Sugandha Arya, who is also an expert in this field from Delhi and North region. Dr. Sugandha, if you have to add on
Yeah.
some points or comments
Um,
on what ma'am and
Actually,
Dr.
Dr. Ravi and Dr. Vani ma'am has already covered most of the things. Just I wanted to add 2 points. One is this lactational counselor. These are not available in most of the government hospitals. There is no post like lactational counselor. In Safdarjung, I've been seeing for the years, and the SNCUs I am visiting, there are no lactation counselors. So probably we from NNF or Government of India, we are also talking that you at least among the nurses, if one can be trained into lactation counselor, it is very important to have a dedicated person for lactation counseling. Otherwise, it doesn't work unless there is at least one person dedicated, maybe in the daytime, but that we need to do. Till we get a lactational counselor post, maybe one nurse can be trained. That's all. The rest, most of the things they have already covered. Thank you, Dr. Amit, for.
Thank you, Dr. Sugandha. Very pertinent point. Again, we have our expert trainer, Dr. JP Dalit sir, who would be taking over the next session. I request sir, on behalf of NNF, to create such a cadre amongst nurses and medical practitioners. Now, Dr. Lalan is here. Sir, your expert comments about topic still here. Before
Oh,
we go on to the very coveted panel discussion led by Dr. JP Dalit sir.
thank you, Dr. Amit. There was some network issue in between. So, namaskar, madam. Namaskar. Sushma
Namaskar.
ma'am, Kumta ma'am. Namaskar, ma'am. And happy breastfeeding week to everybody. So this is not the duty of the mother. This is the shared responsibility of all of us to promote and protect the breastfeeding. As Sugandha was saying, that NNF will be coming for this course soon, maybe this year or next year, definitely, which was started, I think, during the Susma ma'am times. And we are in touch with Dr. Dadish sir, and we will be doing this course for the nurses. And that is need of the hour, ma'am. And this regarding this breastfeeding week. So this is the week where we celebrate, and this is not the opportunity to raise the awareness, but we got the renewed platform to take the meaningful action to support the breastfeeding. This is the one of the most powerful intervention we have for the newborn survival, growth, and development. And at NNF, we recognize breastfeeding as the cornerstone of the newborn health and survival. So together, let us build a future where breastfeeding is protected, promoted, and supported in every home, every hospital, and every workplace, not only in the hospital. And I think this support should have started from the adolescent period, not even during the pregnancy, and that should continue after delivery and in society also. Then only we will be able to do that.
Thank you, sir. Wonderful comments. And we were waiting for your expert comments. Now,
Thank you.
with
Thank you.
those uh, words, we go on to our panel discussion on implementing breastfeeding, breast milk feeding practices, friendly policies in the NICU, which is very important for wholesome, intensive neonatologists. And I am one of them as well. And so for this, I would like to invite Dr. J.B. Dalit sir, who is almost synonymous with breastfeeding in India, promotion of breastfeeding in India. He has worked with BPNI. He has worked with numerous organizations. He is the chairperson of NNF, Breast Milk and Breastfeeding Support, Promotion and Protection Committee for 23-24, and he continues now as well. He is a former secretary of NNF as old as in 2003 to 4, and there are numerous. He's been coordinator for WABA, Global Advocacy Task Force for Breastfeeding, and many others. So over to sir to kindly introduce your fellow members in the panelists in the panel discussion, and initiate the proceedings, sir.
Thank you, Dr. Amit, for the kind introduction. I will start. Before starting the panel discussion, I would like to say namaste to Professor Sashivani, madam. Namaste, madam.
Namaste.
Yeah. So, and all the...
Nice to meet you, Dr. Dadij.
Thank you, madam. Thank you, madam. I will share my screen first, and then I will start. Give me 1 minute. Can you see the slide?
Yes, sir.
Yes, sir.
Okay. So, how did we decide this particular topic for this panel discussion? Well, since the beginning of this webinar, we have heard that how important breastfeeding or breast milk feeding is for the neonates, particularly the sick and tiny neonates admitted in the NICUs. All the speakers, they have highlighted this particular fact. Actually, Dr. Subhash described it very nicely in his presentation. But at the same time, we all know that the status of breastfeeding or breast milk feeding is not satisfactory, particularly in our NICUs. We need to improve these practices in our NICUs. And to improve the practices, we need to implement breastfeeding or breast milk feeding friendly policies in our NICUs. So that is how this particular topic was decided. It's a need of our. We need to work very earnestly to have breastfeeding friendly policies in our NICUs. To discuss this particular very important topic, we have a panel of very eminent experts who have worked extensively in our country for protecting, promoting, and supporting breastfeeding. Let me introduce them one by one. We have Dr. Sushma Nangian. She is the Director Professor in Neonatology at Lady Hardinge Medical College and Collaboration Children's Hospital, New Delhi. She is the immediate past president of NNF. She is the co-convener and convener of National Collaborative Center for Facility-Based Newborn Care, Minister of Health, Family Welfare, Government of India for SNCUs and NBSUs and NSSK between 2012 and 24. She is the convener of National Comprehensive Lactation Management Center, 2017 till date, and a lot of other laurels. It was a long list, so I have just curtailed. I have just put few of them here. Then we have Dr. J. Kumuta. He is the Dean, Professor and HOD Neonatology at Savita Medical College, expert, and she is also an expert advisor in child health to the NHM Tamil Nadu. We have Dr. Kanya Mukhopadhyay. She is the Professor of Neonatology at Department of Pediatrics, PGI, Chandigarh. She is presently the Secretary of Human Milk Banking Association of India, HMBAI, BAI 24-25, and she is the ex-Secretary of IYCF chapter of IAP 22-23 and ex-President of IAP Tri-City branch in 2022. We have Dr. Ruchi Rai, Professor and Head Department of Neonatology, Postgraduate Institute of Child Health in Noida. VP. She has a number of publications in international and national journals, reviewer for many journals, and she's authored many chapters in different books of genetics and neonatology. So let us start the action. The first question goes to Dr. Kumutha. And before we start the question answer session, let me request all the panelists to kindly be brief, because the slides are plenty in number, but we need to finish the answer in roughly 4 minutes. So Dr. Kumutha, why is breast milk feeding or breastfeeding is considered the best feeding option for the tiny and sick babies in the neonatal units? Dr. Kumutha, please.
Thank you, Dr. Dadich, and for National Neonatology Forum for giving me this opportunity. And the first speaker, in fact, gave us the importance of breastfeeding. And it is gold standard nutrition for newborns, and more so for sick and vulnerable neonates. And I have divided into three portions. One, the optimal nutrition for preterms and sick infants. So if you look at the nutrition part, and you know that the nutrients are in ideal balance, and proteins higher in preterm milk, and also high quality, which is very essential and easily digestible. And also if you look at the fatty acids, especially DHA and arachidonic acid, very essential for brain growth and retinal development and maturation. And also the vitamins and minerals, especially A, and minerals iron, zinc, and calcium, optimal for bone strength and organ development, and very essential for preterm vulnerables. And growth factors, because they are in varying stages of development, especially epidermal growth factor and insulin like growth factors, are very essential for the maturation of the gastrointestinal tract, which also forms 70% of the lymphoid system, which is very essential for immune. In coming on to the immunological properties, the secretory IgA is the most important thing, and Subhash really reiterated on IgA too, which is not destroyed by the gastric juice, and that is the most important one. And second, also the other immunoglobulins, and also when you have the cells, immune cells, especially leukocytes, which helps, and more so in cholesterol. We know that the importance of that is why, as everybody said, very important for preterm and sick infants, we get the breast milk expressed and the colostrum being expressed and sent. And this is very difficult in babies who are outborn, which we will be talking later. And so that is very essential. And also the inflammatory cytokines, very essential to reduce the inflammation, very essential in the lung and the intestine, because they are the most hit organ as BPD or necrotizing enterocolitis. And also their better response to immunomodulation. In fact, we have a study that low birth weight receiving BCG had a better immune response if the babies were exclusively breastfed. And also very useful for gut immunity development, and also prevention of sepsis and pneumonia. Then coming on to the long term effects of breast milk, and also the bonding. So because the breast milk feeding by expression and also continuous skin to skin contact, we are able to improve the exclusive breastfeeding, and also the bonding between the two. And also we have better milk production for with the mother. And again, as I've told you earlier, DHA and arachidonic acid plays a key role in brain development. And also the later on diseases, adulthood diseases like diabetes, cardiovascular. And studies have shown that babies who have been breastfed have intimal media thickness lesser, and so their proneness for cardiovascular disease is much less. And also the triglyceride, cholesterol, and the LDL component is also less. So that is a reason for less obesity and more lean body mass, and lifestyle diseases being much less. to sum up, this is a very essential gold standard. Breastfeeding should be given, and more so mother's own milk. When we say breast milk, many of because of the presence of donor milk, we tend to shift towards donor milk, but that should be cut short, and we should strive hard to give mother's own milk, which has got all the advantages, and we don't lose anything by pasteurization also. So it's a personalized medicine for the baby, which we should never deny. Thank you. Dr. Dadich?
Sorry.
I know.
Yeah. So I'm sorry. Dr. Kumta, thank you very much. Nicely summarizing how important it is for the neonates to have breastfeeding or breast milk feeding, why it is considered the best option for them. We come to our second question. Dr. Ruchi Rai. What neonatal morbidities can be substantially prevented by avoiding infant formula in tiny sick neonates? Because in many neonatal units, the infant formula, and they say that it's a preterm infant formula and many other kind of things. They say that it's a viable alternative to breast milk or breast milk feeding or breastfeeding. But we all know that infant formula, they have various problems, and we'd like to know it from Dr. Ruchi Roy, what morbidities they can cause units. Dr. Ruchi Roy.
Yeah, thank you very much, sir. Good evening, everyone. So I will take this question up, and although all of us know regarding the many harms of ill effects of using formula milk, but specifically when we talk about use of formula milk in sick babies and admitted in NICU, I would say one of the most dreadful complications that we should be aware about is is the definite association of necrotizing enterocolitis with formula feeds. And the main reason why these babies are prone to develop necrotizing enterocolitis is that the use of formula increases the gut permeability, which permits the bacteria and the toxins to enter into the intestinal mucosa and triggering inflammation, which precipitates necrotizing enterocolitis. Apart from that, the bacterial colonization, which we'll be talking about in a couple of slides later, also is the bad bacteria grow more in babies who are on formula milk. So this leads to so this study which I have quoted is a randomized trial, and this is of exclusive human milk. This is not only mother's own milk, but this was a randomized trial between the donor milk and the formula milk, and there is a clear increased association of NEC, surgical NEC, and NEC and death in babies who were given formula milk. Next, sir. So as we were talking about harmful gut microbiome that are detected in babies who are on formula milk, so the mother through her breast milk can transmit good bacteria to her baby, and that is what is lacking in the formula milk. So what happens is that the mother can transmit good bacteria, which is like the bifidobacterium and the bacteroids, which are sir, can you please click?
Next slide.
So if you click, so there is an arrow that will come to highlight.
Okay, yeah.
Yeah.
Again?
This is yes, sir. So the red arrows are the bad bacteria that are like the enterococcus and the streptococcus, which you can see are more in the pink or the orange boxes, which are the babies who were given formula feeds, and the blue ones are the babies who were breastfed. So we can see the good bacteria, that is the bifidobacterium, and the bacteroids are found in ample amount in the babies who are breastfed, and this good bacteria that is prevalent in babies who are on breast milk is a protective factor. Therefore, babies all who are on formula milk will have a diverse gut microbiome and more proliferation of the bad bacteria, which predisposes the baby to multiple other issues like sepsis and NEC. Next, sir. Another dreadful complication that all of us are always scared of is retinopathy of prematurity. And all the studies have proven beyond doubt that retinopathy of prematurity is seen more commonly in babies who have been given predominantly formula milk during their NICU stays. So one of the reasons why the formula milk will predispose to retinopathy of prematurity is that it lacks the antioxidants which is present in the human milk. And apart from that, other reasons, other morbidities that are caused by formula milk like sepsis, prolonged hospital stay, NEC will also indirectly and increase the incidence of retinopathy of prematurity. So, sir, can you please click? So, in this slide, we can see that this was a study in which they compared the incidence of ROP as well as severe ROP in human milk versus formula milk, and it is proven beyond doubt in this forest plot that the human milk was protective for the development of retinopathy of prematurity. Next slide, sir. And the other morbidities that we can see more in babies who are on formula milk is because of all the other issues that these babies develop, like NEC, ROP, as I said. So there is an increased duration of hospital stay. These babies are prone for sepsis, and diarrhea is also seen in admitted neonates, which may be attributed to asepsis while preparation of the milk. There is a negative impact on the metabolic profile of neonates also, and it also depends on the protein and the whey content of the formula milk that is being given. There is a higher rate of feed intolerance in babies who are given formula milk, and therefore these babies achieve full feeds much later than babies who are on breast milk.
Next, please.
No, thank you, sir. That ends.
Yeah. So, thank you, Dr. Ruchi, nicely telling us about the risks of using formula milk in our NICUs. It's a kind of why this question is here in this particular panel discussion, because most of time we say that breast milk is best, breast milk is best, breast milk is better, but we very hardly we say that infant formula is dangerous. Actually, it's just like it's a kind of narrative which is going on for since decades. Actually, it's just like in Harry Potter they say that Voldemort should not be named. So we never named infant formula that it's dangerous. We should start saying this now, that yes, breast milk is good, but infant formula is dangerous. So
Very
we come to we come to our next question, question number 3, and this question is for Professor Sushma Nangia. Madam, can you tell us what are we have this debate is there many times we hear that it should be mother's own milk or the pasteurized donor human milk. So can you tell us what is difference between these two, and if given a choice, which one should be preferred? Dr. Nangia, please.
Yeah, right. Thank you, Dr. Dadij, for this question, and thank you, NNF, for organizing this webinar on the World Breastfeeding Week during the World Breastfeeding Week. So when we ask, are there any differences, let's really look at what WHO says. So next slide. What WHO says, so it's very clear that WHO ranking of feeding options for newborns, mother's own milk is the topper, the first one, and what you see as the pasteurized donor breast milk at number 4. So I'll explain why it is like this. Next. So when we look at the differences between mom and PDHM, so mom, the source is infant's biological mother, and that's why it is tailored to the infant's need. If you see the last row, this is what makes it individualized nutrition. Whereas what you have as the source for donor milk is screened mothers, of course, but this is all pooled. It may possibly be all term mothers, and the milk may be something which is much beyond, maybe at 5 months, 6 months, or even later. And this is generic human milk. It's not something individualized nutrition. And what you find in the tailored to infant needs is it is tailored to the gestation. It is also tailored to day by day. So on day 4 vis-a-vis day 7 or day 10, it's getting tailored to the infant's needs. So obviously, that's why mom's source is what is best for the baby. If you look at the bioactivity, it is rich in live cells, enzymes, all the living things are there.
which of course get much reduced due to pasteurization. Microbiome contains beneficial maternal flora, and obviously again, mostly it is inactivated in the donor milk because of the process of pasteurization. Immunological properties similarly are quite high in mother's own milk, but then they become moderate because of some of the proteins that are denatured. Can we go to the next slide, Dr. Dadish? So obviously, mother's own milk is the gold standard, which is preferred choice because it's immunologically active, biologically matched to the baby's needs, and promotes better outcome in preterm and sick babies. But donor milk is probably the next best alternative, especially when mom is unavailable or inadequate, and it has been proven to reduce NEC and feeding intolerance when you compare it with formula. But then it should not replace mother's own milk. Next slide, sir. So if you take a deeper dive, then if you look at on the left side, the lactoferrin, live cells, antimicrobial peptides, and all these very, very important aspects which make the mother's milk unique are all reduced in donor milk as compared to mom. So there is a definite reason to prefer mom. Next slide, sir. So I would call mother's own milk as a crucial medical intervention, not just a nutritional intervention, because of the presence of all these essential components which my predecessor have also spoken about, which give rise to lesser sepsis, lower NEC, better neurodevelopmental outcome, lower ROP, and so on. Next slide, sir. Extended benefits of breast milk microbiota, optimum neurodevelopment. Next, sir. So next to this. So at Lady Harding, what we are doing is we are pumping the milk. We are calling these mothers of preterm babies who are admitted in NICU. But look at the amount of mom given back to NICU and the milk that is donated. It's almost 3 times or higher. So next slide, please. So if we look at cumulatively of all the milk that is pumped, more than 3/4 is given back to the NICU for individualized nutrition for the biologic baby of that mother. And only about a quarter of the total, or less than quarter, is what is pooled and pasteurized. Next slide, sir. So these are some of the key points or key messages which will help us ensuring mom right from the beginning, starting from antenatal counseling and then frequent expression, correct method of expression, and so on. And of course, allowing the mothers in the NICU all the time, unrestricted access. That's all, sir. So the last slide, I think, on this. So final takeaway is that PDHM can work as a bridge, but mom remains the destination. So all our babies should be on mother's own milk. Thank you.
Beautifully said. The final destination should always be mother's own milk, actually, and later on breastfeeding. So I thank you for very nicely saying the differences between. They are not competitor to each other, actually. They are basically the the pasteurized milk is basically for a transitional period, and the ultimate aim is to have mother's own milk.
Exactly. Right.
One slide I particularly liked when you said that breast milk is not sterile. Yeah, but when we say this, the breast milk is containing friendly bacteria.
Yes.
Same can be said for the formula. The infant formula is not sterile, but it contains pathogenic bacteria.
True.
So that is the difference between these two. So thank you. We come to our next question, and this question is for Dr. Kanya Mukhopadhyay. Many times the staff working in NICU, their intentions are very high to get milk from the mothers, but somehow mother is not able to express milk for their babies admitted in NICU. So are there some maternal factors which pose challenges in procuring breast milk for their babies admitted in the NICUs, Dr. Kanya?
Thank you, sir. Can I show the next slide? Yes. So the breast milk feeding rate in NICU is not very good. And at discharge, only 40 to 60% NICU babies are on exclusively either breastfed or breast milk fed. And this rate drops quite hugely after discharge. So what are the reasons for such a poor rate of breast milk feeding or direct breastfeeding at discharge? Because from the beginning only, the interaction with mothers and the methods to keep their lactation going on is not adequate still in our setups, or I would say in many setups. Next, sir. So the possible reasons which I just tried to jot down, that why we are not able to get all 100% mothers to our NICU to get the feeding. So number one, many mothers who are actually sick and cannot visit NICU, because most of the referral centers where these small babies are born, mothers come quite often in a very sick conditions, and then they are shifted to HDU, ICU, like that. So this is one of the major reasons that mother is sick. Secondly, even if she is mobile a bit after a couple of hours, then in many places, NICU is far off from the mother's ward, or sometimes they are even in different floors. Another excuse is post-cesarean section, where mother may not visit for a couple of days. Though after 12 hours onwards, they may be mobile, mother may be mobile. By 24 hours, definitely she is mobile. And specifically in the wheelchair, she can use and come. But the efforts need to be made so that she can come. So that part of counseling is also lacking. Then fourthly, there is no antenatal counseling in most of the places regarding the breastfeeding. So mother is not mentally prepared, and once a preterm baby is born, everybody is in high stress. All the family members, including the mother. So even if you postnatally counsel, sometimes they are not able to think that much. So if a mother is prepared mentally, antenatally, and we have our studies which showed antenatal counseling definitely improves the exclusive breast milk discharge. I did not put all these studies to reduce my timings, so that I don't exceed my time. But we have done our own study. Antenatal counseling significantly improved breast milk feeding discharge at discharge, exclusive breast milk feeding. So it does help. Then even if mother comes after a couple of hours or days, staffs are so busy in most of the busy NICU that no one is there to teach her the correct method of expressing milk. Most of the time they will be given a katori or something and will be told, okay, you go and express the milk. Nobody would teach her the hygiene and that method, and mother on day 1-2 will definitely have some issues, but the support by the staff may not be adequate. Then in a busy hospital, you may be having 1 or 2 counselors, but you have too many patients to counsel. So the lack of manpower in the postnatal ward where mother is sitting is also inadequate covered in most of the busy hospitals. Then there is inadequate family support also. Mother's mother or in-laws, they try to protect mother. They don't allow mothers to, walk or wheel into the ICUs. And they keep saying that mother is not well, mother cannot go. So in such cases, if the mother is really not mobile, then they should get the clean katori for the expression. But somebody again has to teach her the hand hygiene and how to express in the postnatal ward. Some mothers may not be really mobile. And in some private hospitals, mother gets discharged and they do not have any bed. So mother goes away good kilometers away, and from there it is definitely not possible for her to come and visit. So we need to give the mothers after discharge some space to stay. Now, as they have to pay for both baby and the mother, most of the hospitals are not having that facility, or parents cannot afford. Then after the mother is discharged, even if they're staying around, let's say they rent a room or something like that, many hospitals have a very limited visiting hours. And mother can come only maybe in a day, once a day, not more than twice a day. So doing once or twice KMC is sort of many times is not possible. So these are the many reasons why maternal factors play in to have a less mother's own milk into the NICU. Next slide. Yes. So this is one of the picture, like if the baby is even on CPAP in an ICU, and this room is a bit bigger, probably some room designed for the family centered care, if possible, then even if the CPAP or ventilated babies, the mother around and she can continue to give this intensive care with KMC. And Madam, as Madam Vani said, Sachivani stressed so much of this KMC throughout her life. She is stressing on that. It is highly doable. And in the second picture, you can see that mother is not in NICU, she is in the postnatal ward or somewhere close to labor room. If the baby is not that unstable, who doesn't need immediate ventilation, many small babies just get shifted for the observation purpose. So these babies can have maybe 15-20 minutes or half an hour of skin to skin care before moving to before the baby is moved to NICU. That is good enough to increase mother's lactation and stimulates her to visit the baby in the NICU subsequently. And I think I have one more picture.
Yeah.
Yeah. So the father, now till mother is able to come and the baby is stable. This is the father. This is in our NICU who is happily doing KMC. Thank you, sir.
Thank you, Dr. Kanya. Very, very rightly you have mentioned all the how important it is to support mothers, to give more attention to maternal comfort, to have breastfeeding policies in NICUs, breastfeeding friendly policies of allowing uninterrupted visits to NICU, and having a kind of conducive environment there, which is friendly in. I mean, everybody is talking to the mother nicely and talking about her comfort, providing her, asking her if she is having any kind of discomfort and trying to remove that discomfort. We come to our this was part one of our questions. We have a total of 8 questions, so we have completed 4 questions here. So we come to the second stage, second part of our panel discussion, and this question number 5 is for Dr. Komuta. Dr. Komuta, what institutional policies and practices which hinder breast milk availability from the mothers of the sick babies? I mean, there are many policies in the institution itself, which actually, if mother is even willing to give breast milk, they hinder that particular process. So, can you tell us about these things?
Yes. Can I have the next slide, please?
Yeah.
See, if we can significantly, they can produce a good impact if that is given. But barriers in healthcare already Dr. Kanya has told us, and I'm not going to dwell on it. I'm going to tell where it can be modified or where it has worked in our practice. Next. See, first is inadequate lactation support services. As Sugantha told, there are no lactation consultants or lactation support people in the institution, whether it's a busy labor room or in the NICU. So, uh, in fact, even if central NHM sanctions at the state level, then lactation consultant post gets knocked off. So we don't get support from the government. So more so in private hospital also, many consultants keep hopping from one hospital for 1 hour and go to next private hospital for the next hour. So the best option as of now, I feel, is for the nurses to get trained, at least dedicated, identified nurses to be trained on lactation management and support, and that has to be done. And again, everyone should have a structured policy as whatever skin to skin contact for 1 hour. And as Dr. Vani madam said, it should be audited. Unless we look how much we are doing, we always tend to think the practice is being done. In fact, in our hospital, we did it, and the nurses are the ones who are recording. And they have also recorded for 30 minutes, 45 minutes, or 60 minutes the first skin to skin contact. And when we sit with them and talk why it was not done, and we are asking for solutions from them only, they are able to give. And we are now including birth companion also. That is number one. And number two, many of the hospitals do not have postnatal beds. The minute the mother is fit for discharge, they are all discharged, but the babies may be staying for many weeks in the NICU or in the SNCU. So that provision should be done by the administrator, that a postnatal bed has to be done. In government hospital, the problem is in the crowding, and in private hospital it is the costing, where they have to pay for the postnatal beds. So many of the hospitals now are looking into it, and they are giving subsidized rates in private, and in government, in fact, we are creating postnatal beds for mothers whose babies are admitted. Can I have the next slide, please? And the second one is this policies on milk expression. That is, the minute the mother has delivered, they have to go for milk expression. Even if the mother is little unwell, the nurse, the lactation support person, or the nurse from the NICU or SNCU goes to express. In our hospital, even in the ICU, we have created a conducive environment there. The doctors are very, very supportive, and they cooperate with us for milk expression, even for the mothers who are admitted in the ICU. Number two point is not only the first milk expression episode, but also the subsequent milk expressions in a regular basis, second hourly or third hourly, as a child would breastfeed. That is the most important thing. And again, early skin to skin contact, getting the mother as soon as possible. And if the mother is not there, we are allowing one relative to come and have the contact. It could be an young uncle who's unmarried, sister or nephew, niece of that mother. They are coming and giving, and that support is given for early skin to skin contact also for the baby. Next. Third, again, poor access to milk expression facilities. And again, what more to adopt? This knowledge is not there. Everyone in the early phase of lactation, that is in the first few days, they are trying to do the breast milk pumping, especially hospital grade. Hardly anything comes, and then it gets stuck to the breastfeed, the pump and the bottle. And so we have to tell them that the manual expression in the early phase is much better than using the pumps. And again, when they start using the breast pumps, individual small pumps may not be very helpful. When they use a hospital grade pumps, electronic pumps, the pumping becomes better. And also, same time, simultaneous pumping of both breasts. This also we have to teach the nurses, and we have to educate the mother. And all these things, as Kanya said, education before, either in the antenatal period or in the natal period, where the mother would be expecting a baby who might go into the NICU. All this has to be done. If the mother is elsewhere, if the mother is elsewhere in another hospital, that transport also we should see. And most of the fathers and everyone are used in the transport of milk from another institution. So that is also very essential as a policy we have to do. Next. Then socio-cultural barriers, restricted NICU, please, restricted NICU access, and that has to be taken care of. And 24 hours of free access for the mother, and the father should be there definitely for you to have. And if the mother is not secreting enough milk, lot of emotional support is needed. That is wherein this lactation support person is very, very essential for them to support. Next slide, please. Next slide, please. Okay, so to sum up, the policy of having a trained person and unrestricted visitation to the NICU, and also even if the mother is in odd situations, milk expression should be done. Instead of telling the birth companion to go and get the milk, I think somebody from the neonatal nursery or the trained person should go and start initiating the milk expression, and then teach them and integrate in the NICU care. That's when all this helps. And this, I think, as a government, I know Sushma is here, we have also in places where CLMC is there, at least we have told them lactation consultants, 4 in number, should be placed. I think the states should be mandated to follow the center's guidelines in this, and also all our neonatologists should have unrestricted visitation policy, because many of the nurseries, when we go for visits, still they are not allowing mothers. They only have certain visiting hours, and especially if they are discharged home, they are very much coming in the morning and evening expressing, and some milk expression goes at home maybe once or twice, which is not equivalent to the breastfeeding a child would have had. So these are things I think which would go a long way in improving. Not only the administrators suppose policies, and our practices also should improve. Thank you. And again, another point I wanted to tell you, the presence of CLMC is restrictive nowadays. Every nurse feels very comfortable to pick up the pasteurized donor milk from the CLMC, and then she doesn't encourage the mothers to express and get their own mother's own milk. So having a track record of how much pasteurized donor milk is being used in the nursery is very, very essential for getting on to the destination, which Sushma said, which is mother's own milk and our own breastfeeding.
Yeah. Thank you, Dr. Komuta. Very clearly highlighting what are the hurdles which are there in our NICUs to procure mother's own milk. One thing which has come up again and again is that we should have training of nurses, because that is one doable thing, feasible thing, which probably is also the, when this year's WBW theme is also creating sustainable support system. So that can be a part of sustainable support system. So because the nurse is there in the NICU for a prolonged time. I mean, when you say that the consultants are there, they are spending only 1 hour in one hospital and then going to some other hospital for 1 hour. But the nursing staff is there for a prolonged period. I mean, either 8 hours or 12 hours duty. So they are there every time for the baby to
Actually, we have assigned certain nurses in each shift to be in charge of lactation support.
Yes, yeah. So this one task is which NNF can take up, because other organizations, they are doing trainings, but they are doing for complete infant young child feeding, and it's a long training for 7 days or 10 days, 14 days. The smaller trainings only for lactation management, and that too are tuned towards the needs in our NICUs. That can be, and it can be an online kind of thing, and then there can be a contact program for 1 or 2 days for skills. So that work can be taken up by NNF. Just like because NNF also has the experience of doing a number of other programs for nursing training. So the track record is there, and the lactation management can be added to that one. So we come to our next question, question number 6, and this is for Dr. Ruchi Rai. Dr. Ruchi, what are the evidence-based methods to enhance breast milk supply in the mothers of babies, those who are admitted in the NICU?
Yeah,
Dr.
thank you,
Ruchi.
sir. Next slide, sir. So there is a beautiful document by the WHO and UNICEF which they came up in 2020, in which they have detail they have mentioned how we can protect, promote, and support breastfeeding in baby-friendly hospitals, and especially for sick and preterm babies. So we have talked about it so many times earlier in this talk itself. So there is antenatal information that needs to be given to the mother, immediate skin-to-skin contact. An early expression is very important. So now here we are talking about babies who cannot directly breastfeed. So if the mother we need to counsel the mother to start expressing very early. And if there are studies to show that if they start expressing as early as less than 6 hours after birth, so it can go a long way in sustaining the mother's milk output. Early initiation of breastfeeding again. So many times the baby has improved, but we are reluctant to put the baby to the mother's breast. So distress has settled, everything is settled, but we still continue on OG feeding or palliative feeding. So we should be able to initiate breastfeeding in such babies much earlier. Another problem we face is that stable infants, even if they are stable, but just because of their gestation age and breast and birth weight, we somehow are scared to put the baby to the mother's breast. So we should try and assess which baby is ready to accept the mother's breast and start it as early as possible, and then manage common problems which are faced by the mother, and there should be uninterrupted time between the mother and the baby. Next, sir. So quality improvement initiatives have been done, and multiple papers are there on how to enhance the mother's milk output. So whatever science may be there in the benefit of breast milk, but when it comes to the improvement in mother's milk output, we need more of art and counseling. So the multiple quality improvements are required in NICUs, which can be a combination of counseling of mother and father and the family, both antenatally and postnatally, training and orientation of the staff, dedicated lactation staff, early expression of milk, availability of medical grade breast pumps, skin to skin contact, and there should be regular monitoring of breast milk intake, meaning that when we take the rounds of such babies, just not only what medication and how the activity of the baby is, we must always ask how much the milk intake of the baby is by the expressed breast milk. Next, sir. So just wanted to quote two studies in which they have used a multitude of these quality improvement initiatives. In the first study on the top of the slide, there has been, sir, can you please click? So there has been a steady improvement with all the quality initiative that was done in the unit, but it is easier said than done. So we have another study which is on the lower side of the slide, in which they demonstrated that in spite of all the efforts that they did, there was not much improvement in the and in fact you can see that at the time of discharge, the breast milk feeding with breast milk actually decreased. So it's a time consuming process. We need to be patient, and it is not that easy with anything we intervene. Next, sir. Another thing that we must talk about is family centered care. And this study definitely tells us that breastfeeding rates in the admitted babies increased when in the intervention group, in which there was family centered care, in which the mother, father, and the other family members were allowed freely to enter and care for the baby. So, sir, can you please click? So the breastfeeding rate in the control group was just 66.7%, and in the intervention group, it rose up to 80%. So that needs to be promoted. Next slide, sir. So one slide I would like to show about galactose, although that is not the first thing that we resort to, but most of the studies have shown that there is an improvement in the mother's milk output with the use of domperidone, and the same promising results have not been shown in metoclopramide. So can you please click? And similarly, and if we do a subgroup analysis, the results were better when we use domperidone in mothers with preterm babies than with term babies. So can you please click? So we need the increased milk output more in preterm babies, because these are the mothers who will need to express. So maybe it can be used transiently, but most of the studies have shown that on long-term basis, this is not of much use. But maybe for transient, if no other modalities, we are achieving success, so maybe we can use domperidone in such mothers. Next, sir. So to sum up with whatever the NNF CPG guidelines have told us, what we have discussed, that the mothers whose infants are admitted in a neonatal unit, so we must promote the use of electrical or manual breast pumps if they are available and there is no resource constraint. KMC should be routinely used for all low birth weight babies, and there is a strong evidence for this. Domperidone, the NNF says that domperidone may be used to enhance milk output, although it is a weak and conditional recommendation, and there is a strong recommendation against use of metoclopramide to enhance mother's milk output. Next and last slide, sir. And then there are strong recommendations that skilled personnel, that is dedicated skilled personnel, if we have for promoting lactation in the mothers, then low cost intervention like breast massage, breast warming, and relaxation techniques, non-nutritive sucking, and peer support will definitely go a long way in improving the milk output in such mothers. Thank you, sir.
Thank you, Dr. Ruchi. And I must say that we are finishing our answers well within time. So that is good. So we go to our next question now. Question number 7. Professor Nange, what is the role of Kangaroo Mother Care, though we have discussed it in detail in one of the presentation by Dr. Ravi. Can you tell us the importance of Kangaroo Mother Care in establishing breast milk supply in mothers of preterm babies?
Yes. Right, so thank you. And yeah, there is definite role. Let's look at the physiologic basis and the psychological impact. So physiologic basis is when skin to skin contact is happening during kangaroo mother care, what is it? It feels very good to the mother. It's always a feel good for the mother. No mother has ever said that I don't like doing kangaroo care. So when that feel good is there, it stimulates oxytocin. And with oxytocin, the milk letdown or milk ejection is so eased out that the milk flows easily. That's why the skin to skin care, and additionally also it enhances the prolactin secretion, so which supports milk production. So both the aspects of milk production and milk letdown are facilitated by KMC. So this facilitates the hormonal synchrony for lactation, and for preterm babies it's very important that that stressed mother now relaxes when she is holding the baby in skin to skin contact. Next, sir. And then it has the psychological impact on the mother, that it builds her confidence and emotional bonding with the baby. It reduces her stress and anxiety, and it supports the maternal readiness to eventually breastfeed, because in between, next, sir, in between, there is this is helping for non-nutritive sucking, and the mother is also able to assess the feeding cues that my baby actually wants to probably now latch onto the breast. So this encourages earlier shift from tube feeding to breastfeeding. What was being alluded by some of the speakers earlier, that this is one of the barriers, or this is what delays it. So with skin to skin care, this becomes much easier, and it strengthens the neonatal rooting and sucking reflexes whenever the mother shifts the baby towards the breast from the kangaroo position. Next, sir. So what do we see as the outcomes? There is early initiation of sustained exclusive breastfeeding. We can discharge the babies earlier, improve lactation success rates overall, and reduce reliance on formula or donor milk. I'll show one or two pictures. So what we are seeing here is grandmother and some aunts and other family members providing kangaroo care. A mother providing kangaroo care for her twin babies. So it's not that she has to provide one by one and she gets fatigued. She can actually do it for both the babies. Next, sir. So here is something that we follow in our unit. For every week, we have the KMC champion in the NICU, the mother or any other relative who's doing maximum hours of kangaroo mother care for that week. So we are tracking it every day, and then our nursing personnel will be providing them a KMC champion cup, which stimulates them. There is peer kind of competition, that I need to, if she does 9 hours, I need to do 10 hours. If she does 10 hours, I can even do 11 hours, and so on. Next slide, sir. So what you see here on the upper panel on the right side is two fathers doing kangaroo care for their babies who are on CPAP, and their mothers are standing next to it. This is just for picture purpose that they were made to stand next. But yes, fathers are coming in and doing kangaroo care. You can see almost 3 panels showing father, mother who are there, and only 1 panel showing traditionally just the mothers doing kangaroo care. One more addition that we have done, next slide, sir, is having a small baby ward where we keep babies between 1500 grams to 1800 grams if they are stable right at birth, so they do not crowd our NICU, and they are being looked after by nurses over there. And so you can see there are 4 rooms like this with 4 beds, 3 rooms like this with 4 beds in each. So we have a 12-bedded unit that decongests our NICU, and the babies are with the mother all the time in skin to skin care. They are getting mother's own milk, and their warmth is maintained. So these babies don't become sick, and we don't get them back in the NICU. They are discharged after a variable stay in this small baby ward. Next, I think that should be the last one. Yeah. So, and we have a collaboration with the Norwegians. So we had the Norwegian Norec CEO come to Lady Harding, and the Norwegian ambassador come to Lady Harding to see this project as to how well it is going. So with all our nurses and the people in the milk bank, so we have the CLMC in the background of CLMC. This is the picture that's there, and they are very happy with the progress, and we of course are very, very happy with the way things are moving. Thank you so much. Thank you, sir.
Thank you, Dr. Nangia, very nicely describing how KMC helps actually to procure
Breastfeeding.
mother's own milk, and also showing us glimpses of some very inspiring work which your unit is doing. So thank you very much. And now we come to the last question of our panel discussion. And this question is for Dr. Kanya. So Dr. Kanya, what policy and practices interventions a neonatal unit should implement to make it breastfeeding friendly? Because we have heard about baby friendly hospital initiative, and some say that it's breastfeeding friendly hospital initiative. But we are discussing about neonatal units. So are they different than the hospital one, or there are some specific policies and programs which should be improved in neonatal units? Please tell us. Thank you.
Can I have the first slide? Now, most of the things have been already answered by previous three speakers. So, I would just add on maybe few. So in our NICU, what we are doing is very baby unfriendly practices, which we are all aware of. We are separating the mother and baby, and easily the formula feeding is given to this baby because the staffs and all, they always say they are so busy, they will not call the mother. If mother has come on her own or somebody insisted, mother may come. And if there is no milk bank, then the next step is to give straight away formula, which is quite frequent in a non-CLMC NICUs. Then sometimes the consultant also are over enthusiastic, and then they target, the typical 15 grams per kg per day, that target. And if mother is falling short of few ml or something, then they tend to give the extra milk if there is no CLMC with the formula milk. So that too much targeting of weight gain is important, but then you should try to improve mother's breast milk output rather than changing over to formula in that. So this is also a very baby unfriendly practice in many NICUs. Delay in starting feed is very common, especially if the mother had AEDF or REDF. So we had our own studies, and we are able to start feeds by 2 hours in AEDF. And our recent study, we are starting now in REDF. Earlier, the practices where nobody would touch them for 24 hours. So we have come down in both of them by 2 hours and 6 hours, provided clinical examination is normal. And delay in the expression of milk is quite universal. And again, because either mother is not coming or nobody is calling them, there are many reasons which I just answered in the first question. Next, sir. Yes. So what NICU interventions can improve the breastfeeding rates in NICU? One is that training and motivation of nurses in NICU. They are overburdened in most of the setups, but still we have to sort of motivate them and orient them towards the advantages of breast milk feeding and the advantages of early expression, so that they call before, even if you have CLMC, that as Madam Kumuta said, there is a lot of misuse and overuse of the donor milk. If mother is not coming straight away, they will indent. So that's why we have a very strict policy. Before they send an indent to the milk bank, they have to check the mother about their output. They have to write the output, then only we would give them milk. And once it is beyond 1 week or so, we are again very strict and keep on, our counselor should go and check the mother why their indent is still coming from the NICU. So the training of nurses, motivation of nurses is very important. And as I said earlier, that antenatal and postnatal counseling, they do improve the exclusive breast milk feeding. Early expression of milk is very important. We know that expression must start within 4 hours, and it has a long-term advantage. Longer the exclusive breast milk feeding, the earlier you start the expressing. Early KMC already highlighted. And along with KMC, every baby must have also non-nutritive sucking. And some slightly bigger babies who are about 32, 33, 34 weeks babies, who have already stabilized in the NICU, they can be tried on early direct breastfeeding, because their maturity is not, sometimes they can suck well. So early direct breastfeeding also improves the breast milk feeding rate at discharge or direct breastfeeding rate at discharge. Many times we are very scared and go theoretically, no, we will not give the direct breastfeeding before 35, 36 weeks, but we can try that in 33, 34 weeks also. Then is the family integrated care. Already Dr. Ruchi told about it. Now the concept of family integrated care is not new. It is there for last 2.5, 3 decades. But somehow in our country, that is not a practice till now. And there are many reasons for that. One is that, as everybody highlighted, the restricted entry of family members because of many reasons. Even parents are not allowed all the time. So forget about other family members. And second, about redesigning of the NICU. In most of the government hospitals, it is not possible because of the constraints of space. But these days, all big hospitals are having advanced maternal and child care center. So if you are building a new facility, you may try at least some beds where this is a big room where the family can stay and give continuous care to the NICU babies. So family integrated care is very important. Next, please. Next slide, sir. Yes. Now implementing BFHI for sick babies. So this document is very good, and step by step they have told that how each step can be done in the NICU. All the 10 steps of this BFHI can be practiced in NICU. Next, sir. Next slide, sir. Yes. So these are the 10 steps. There are some extra steps also. So I'm not reading out all the steps, but if you look at the 10 steps and if you match here, you will find all the steps are incorporated in it, and of which antenatal counseling I have red highlighted, very important. Postnatally, as soon as mother is stabilized, some counseling, and early KMC, early expression of milk, and supplementation. So you have to really restrict yourself to give the top up milk. Unless this is for slightly bigger babies where there are some hypoglycemias happening in postnatal ward, some excessive weight loss. In those cases, you may have to give, but in most of the cases, mother's own lactation, you have to try to improve mother's own lactation so that you don't have to give the top milk. And also, by allowing mother to NICU, they will learn this responsive feeding. So if they're handling the babies, they will be able to identify the baby's cues for the feeding. So you have to support mothers to come in, stay very long period so that they learn all this. So all 10 steps are implementable in the NICU. Next, sir. Next, please, sir. Yes. Now, mother needs support. Again, highlighted by others that you have to call her if she's not able to come. Do it in the postnatal ward. Postnatal ward. Teach her how to do it. Hygiene, clean katori, etc. 7 to 8 times in 24 hours, and at least once at night. If mother is able to come to NICU, allow her to express bedside than in a cornered room, because if she looks at the baby and expresses, the milk output increases. And definitely teach her hand hygiene. And if she's willing to use the breast pump, then hospital grade breast pump after 3-4 days, once her milk output has increased. As Kumuta madam said, that first 1-2 days, it is better not to use because you will not get any milk that time. It creates frustration among mothers. It can be used only the first phase just to stimulate the breast, but not for expression phase. So after that, if mother wants to use breast pump, you can allow that. However, there are difficulties in some cases where they need more focused care, and counselor may help. Next slide, please. Yes. So use donor milk, avoid formula, but no overuse or misuse. Next, please. Yes. So family-centered care, you can see the elder brother, sister, everybody is there with the parents. They are doing it. But the second picture is very wrong. The father is giving bottle feed. Okay, that's why I put a red cross over there. That is not to be done. Next, please. Next, sir. Yes. Now, this micro environment in the NICU, this is basically the developmentally supportive care. Why I have put it here to increase the breast milk feeding in the mother. That yes, it is very good for the baby. We should be practicing everywhere, in every NICU. Okay, but what we do here, we teach the mothers also to practice this, because nurses are very busy. Many times their positions are very bad. So we actually teach the mother that what is a good position. And if some big light is on their bedside, then to switch it off. They obviously cannot speak loud, less noise, because sister will mind, but at least less light, good positioning, good nesting. All this we teach mothers. Now this help in both ways. It is good for the baby, as well as handling of the baby by the mother improves it reduces her anxiety, and it improves her lactation. So, and also we encourage mothers to talk to the baby, and sometimes, like, reading those storybooks or local religious things. Mothers do come and sit there and read all those books. I think that's all, sir. Is there any picture later? Okay. So the keys to good NICU environment is the staff education and support. Parental education very important, along with the full family. NICU environment has to be appropriate, and psychological support to the mother, as well as the family members, as well as to the staffs and residents. I think that's all, sir.
Yeah.
Thank you.
So with this, we come to the end of our panel discussion, and I would like to thank all the four very eloquent experts, our panelists, Dr. Sushma Nangia, Dr. J. Punita, Dr. Kanya Mukhopadhyay, and Shirai. They answered all they dealt with all the topics very nicely. We basically discussed how important it is to have breast milk
So you
feeding.
can stop sharing the slides so that all of us come on screen.
Yes. Yes. Yeah. So it was a nice discussion. We basically dealt with how important it is to have breastfeeding in neonate. We were particularly focused about babies who are admitted in NICU. We also know something about what is the difference between MOM and the pasteurized donor human milk. The hurdles, why mothers are not able to express their milk, why NICUs are not using mother's own milk, why they are using formula instead, because PGDM is not available everywhere. We also discussed how we can, rectify the situation, what policies and programs we need to implement. And one thing which came out very strongly was the training of nursing staff. While this discussion was going on, one thing which came to my mind was that for this particular webinar, if we compile all the information which was shared today by all the speakers and the panelists, we can develop a kind of nice review article on this topic. If we all agree, we can do it. I mean, so that is it. And thank you again very much.
Dr. Dajit, if you permit just 1 minute.
Yes, madam. Yes, madam.
While we are discussing on this topic, I have been thinking about it for a long time, which I want to put it here. Just like 10 steps for breastfeeding have come up, we should integrate them with the 10 steps of Kangaroo Mother Care. Because many things we find they are quite common, starting right from antenatal thing, providing developmentally supportive care, early initiation of breastfeeding, monitoring and all. So I think we should sit. There are already people have developed endpoints for KMC. We should sit and analyze, adapt them to our needs, and we should be able to bring out a very nice recommendation on this. So
Very
please
good.
give a serious thought to it. And I request NNF to take up this as a special project and work on it.
So Dr. Amit is there, Dr. Lalan is there. So I
So,
hope they are
sir,
listening to this
sir,
suggestion from Madam.
thank you, sir. Dr. Amit just informed me that he had some emergency at his hospital.
Okay.
So therefore, I have been assigned for closing remarks and everything. So thank you, sir, for wonderful panel discussion. And I am sure this the greater insight will help us all our members to propagate, protect, and promote breastfeeding and neonatal healthcare at large. So I again thanks all my chairperson, especially Dr. Sasivani ma'am. She's in abroad, and then again she's joining panel discussion and everything, and whole from since beginning to the end. So thank you very much, ma'am, for your blessings, encouragement, and your support. Your words are very well taken, and will definitely communicate and convey to the NNF, or we will take into the consideration. I thank all my panelists, Susma madam, Dr. Kanya madam, and Dr. Ruchira ma'am, for sharing their personal experience and their thoughts on the exclusive breastfeeding and how it is to be promoted, because everybody knows that they are the needless to say about the benefit now, and but now it is to be scale up. And I thank earlier my speaker, Dr. Subhas, and chairperson, Dr. Ramesh Chaudhary, for sharing the session, and all my panelists and all chairpersons, and especially our president, Dr. VC Manoj, and our Secretary General, Dr. Amit Upadhyay, for giving this opportunity to closing these remarks. And again, I thank you all, and uh, hope to see you soon in another platform and in a platform for propagating the neonatal healthcare in our country. Thank you so much for joining. आप सबका बहुत बहुत धन्यवाद.
We
Thank
all
you very
can
much. It was a
start
very
our
nice
video,
session.
then we can have a screenshot. We start our videos. Yes. Yeah. Okay.
Thank you and good night.
Thank you so much. Thank you.
In the
Thank you,
groups,
everybody.
photo.
Bye, everyone.
Thank you. Thank you, everyone.
Thank
Thank
you.
you. Thank you.
Bye.
Right.
Thank you.
Bye,
Thank you.
everyone. Bye-bye.